Sir, we good to go?
Yes.
Good evening, everyone. I am Dr. Amit Gupta, Joint Secretary, Diabetes India, and we are at the day 3 of Snapshots from the ADA. And as you all know, since last 2 days, we learned a lot in different streams, and today is the day for the diabetes technology. And to welcome all of you, we have with us Dr. Bansi Sabu, who is currently the Secretary of Diabetes India and the Chair of the IDF Southeast Asia. So, Dr. Bansi Sabu, over to you.
Thanks, Amit. As we decided that Diabetes India should do webinar for 4 or 5 days to get many new topics which were discussed in American Diabetic Association. We all know American Diabetic Association is one of the largest meeting in the world with a lot of new things which we can learn from ADA. There were more than 2,000 papers were there and many deliberations from all over the world and all experts from US and many parts of the world. We thought of that everyone can't attend the meeting, but something which we learn from there, at least through webinar, we can reach out to thousands of the doctors across the country. Yesterday, we were having, this flyer had gone to more than 25,000 doctors. More than 2,000 doctors are registered for today's webinar. And maybe at present, we may have more than 600, 700 doctors who are already logged. There are many topics. It's not possible in 5 days to cover completely, but few interesting topics at least we can discuss. We have today 3 eminent faculties. To introduce them, we have Dr. N. Karan, and we invited all the chairpersons and faculty or speakers who were there physically. Dr. Karan was there. He's a consultant diabetologist at Chandra Diabetes Care Center. I welcome Dr. Karan, and you please introduce Dr. Jyotidev, our first speaker. Then we will have Manoj or Supratik, who wants to speak second one, and then we will have third one. But after each talk, we can have few questions because these all 3 topics may be different. And again, at the end, we may have some discussion. So now over to Dr. Karan for introducing Dr. Jyotidev.
Good evening, all, and thank you very much, sir, for the great opportunity. And also, I'd like to thank Diabetes India for the wonderful opportunity to give one of the part of these prestigious ADA snapshots. We are enjoying the third day of the ADA snapshots. Yesterday, we had a wonderful session by 3 speakers, and one of the important session was given by Professor Shashank. He was covering the entire incretin journey and the latest incretin-based therapy, and also we are the learning of both fat mass as well as lean body mass and related with inclisiran therapy by Sanjay Agarwal sir also. So today we have 3 interesting sessions, and the first session will be on the future of the advanced it is automated insulin delivery system. This session should be delivered by our own the king of the technology in India, Dr. Jyotidev Keshav. It's a great pleasure and honor to introduce in this prestigious forum. Sir is MD FRCP, is the chairman, Jyotidev's Diabetes Research Center, is the editor-in-chief, International Journal of Diabetes and Technology, is the organizing chairperson, Jyotidev's Professional Education Forum, the National President, Diabetes Technology Trust of India, is the Central Executive Committee member, RSSCI and AERO, so organizing chairman, JPF annual convention of 12 years. He is a managing trustee, Keshav Trust, engaged in charity and literary activities. He conducts the monthly diabetes education via the YouTube channels and other platforms. He publishes a monthly internet-based free diabetes journals and chapters in textbooks. He is a pioneer in the cost-effective treatment of diabetes with the use of telemedicine and technology. JDC is an IDF recognized Center for Excellence in Diabetes Care and Center for Education, and JDC accredited for RSCA certified course in diabetology for doctors. So with the advent of the technology in the space of metabolic sciences, the evolution of AID, that is automated insulin delivery system, represents a major leap forward in diabetes management. For that, I invite Dr. Jyotidev Keshav, sir. Over to you, sir.
Thank you. Thank you very much, Dr. Kannan, for those words of introduction. So before I start, let me thank Dr. Benshi Sabu, my dear brother and friend, for giving this opportunity. And hello to Dr. Manoj, hello to Supratik and all my friends. So let me start sharing these slides. And this is Dr. Benshi Sabu's vision to have the best of ADA via the Diabetes India platform. And I am given the task of discussing the future of automated insulin delivery devices as discussed in the ADA platform. So ADA got over a couple of days ago, and we were all physically present at the American Diabetes Association. And these are my overall disclosures. I have nothing to disclose pertaining to this lecture because I'm going to discuss on the future of AAD. So let me start with the official launch of Libre 2 Plus, and these are some of the snapshots when Dr. Tade Batilno, along with Dr. Benshi, Dr. Manoj, Dr. Shashank, Dr. A.G. Unnakrishnan, Sanjay Agarwal, and all of us were there for the Libre 2 Plus launch at the JPF venue in Trivandrum, and that was a week ago. And this is a milestone for the development of automated insulin delivery, Libre 2 Plus being a integrated CDM. And this is again a picture that I have taken from the ADA venue when Libre 2 Plus and Libre 3 Plus. So they have actually discontinued or going to discontinue 2 and 3. And 2 Plus and 3 Plus both are integrated continuous glucose monitoring devices, and these wirelessly connect to most of the insulin pump popular manufacturers such as Omnipod, Tandem, Beta Bionics, that is Islet, then Tandem, including the Tandem Mobi, and also the upcoming twist. And twist is available only in some selected markets around the world. And before I begin the discussion of automated insulin delivery, this is a basic. So AID, for those who are not familiar with, it is the conventional insulin pump which connects via an algorithm to a continuous glucose sensing device. So very simple. Here the control algorithm is important, and the accuracy of the sensor is also of very much importance. So let me now review the ADA standards. When are you supposed to recommend? When are you supposed to use an automated insulin delivery device in your practice? So the ADA instructs or endorses the use of automated insulin delivery as a preferred method of insulin delivery in all people, youth and adults diagnosed of type 1 diabetes, because that is a preferred one to reduce the occurrence of hypoglycemia and also to enhance the time spent in range. And this can also be recommended in other types of diabetes, including gestation diabetes or type 2 diabetes, when you find it difficult to manage. But the choice of which AID to use is based on individual circumstances, preferences, and needs. So this is the overall recommendation, and it is somewhat similar from ISPAD, from ETTD, the RSSDI, and so on. Look at this picture. This is a very important picture. And this is the broad landscape of those devices available in the global market. And these are the popular automated insulin delivery devices. I have listed 1, 2, 3, 4, 5, 6 devices, and the fourth device is Medtronic 780G, and that is only one which is currently available in the country. And for Medtronic, they describe this as going back to the future. They are renaming the nomenclature in future will be Minimed, and that used to be the earlier name for the Minimed Medtronic insulin pump. So very soon it will be known as the Minimed 780G pumps. And then you have the Dana pump from South Korea. You have Omnipod, the most popular patch pump from Insulet. And then you have the Beta Bionic pumps, and then you have the Tandem T-Slim and the Tandem Mobi. So what is this Tandem? This is Tandem Mobi, and Tandem Mobi, it is one of the tiny pumps. I would call it as the world's smallest durable automated insulin delivery device. And this is rapidly picking up. It is an automated insulin delivery device. So moving on to the next slide, and this is the story of that automation. This is the journey of that automation starting from stage 1 of automation when it was only threshold suspend pumps. And then we moved to the predictive algorithms. And in the stage 4 of automation, it is described as the advanced hybrid closed loop systems. I think it is stuck now, so I will share it once again. And this is the fifth and sixth stage of automation. And we are tonight looking forward to the second generation, and that is stage 5. And then third generation, stage 6 of automation, which will be the fully closed loop systems, which are not yet commercially available in the market. And that is exactly the future of automation with insulin pumps. And I cannot forget this picture. I cannot forget Damiano and his son David. My friends and colleagues could have seen these pictures many, many times in the last 10 years during my course of presentations on artificial pancreas and AIDs. On the left is David when he was a baby, and he was diagnosed of type 1 diabetes at an extraordinarily young age of 11 months. And in 2005, the father, who is an engineer, he started experimenting on pigs. And that is a beginning. And these are the statements from his son, David. I know the motivation of my father is me, but I know his discoveries and innovations are more than for me. It's for everyone in the world with type 1 diabetes. And I think he's really great. And I'm really proud of my father. And this is in 2023, May of 2023, when Damiano and his group, and now it is Beta Bionics, and starting as a do-it-yourself, now it is a well-established company, a device manufacturer, and they got US FDA approval. And this device is the iLet Bionic Pancreas. And the same year in 2023, and this is me along with Damiano, there is a small booth at the American Diabetes Association, the Beta Bionics group. And this is the same Beta Bionics in 2025 at the recently concluded American Diabetes Association meeting in Chicago. And this was a vast area, and their presence was felt everywhere. And they even had a real world experience. And within 2 years of FDA approval, Beta Bionics have now 16,000 users, more than 16,000 users. And this is the baseline hemoglobin A1C at 8.9%. And this is 7.3% hemoglobin A1C, real world experience after 2 years of use of Beta Bionics. And this is the performance of psychosocial as well as the clinical outcomes with the iLet Bionic Pancreas. Very, very impressive data. Moving on to a new system, and that is a twist system. Of course, this is also an automated insulin delivery, not incorporating AI at present. Of course, a basic AI is there, and it works with Freestyle Libre 3 Plus sensor, as I have shown earlier. And there are a couple of features which are highlighted. One is the size of the pump. And then, you know, when you're using an insulin pump or an automated insulin delivery device, a very common challenge will be the pump blockade. The infusion set can get blocked. And they claim, the twist system, they claims that with iSugar technology, there is a 9 times faster detection of blockades. And there is a personalized glucose management. And this is me holding the device on my palm so that you can make a comparison of the size. It is a very, very tiny device, the twist system. And the preliminary clinical data, a TIR of 70%, level 1 hypo 2.1, and a level 2.2%, suggesting very, very low occurrences of hypoglycemia and clinically acceptable. And for regulatory approval also, these are acceptable parameters. And this is currently available in limited markets, and it is available in the United States. But what are the limitations of the twisted system? Looking forward to the future, we are actually looking for advanced algorithms which doesn't require a meal announcement. But these systems, similar to the minimal 780G, the hybrid closed-loop systems still require the meal to be announced. That means for those who are new to these terminologies, when you are using an insulin pump or an AAD, if you need to calculate the carb and then bolus, this is called a meal announcement. So the future systems are actually getting experimented to eliminate the manual bolusing. So moving forward to the next era of advanced, and these are artificial intelligence powered closed loop algorithms. And these are much more advanced, and AI powered algorithms are meant to adapt in real time to the physiological requirements such as stress or illness or menstruation or exercise. And these are meant for approaching full automation without the requirement of meal announcements. So how is it possible? How can you make it realistic? For that, you require a digital twin model. So most of you are familiar with the term digital twin. And for automated insulin delivery, this is a computerized copy of our own body's glucose and insulin dynamics. And when you are developing an automated insulin delivery, the digital twin can support the doctors and also the system for training and for practicing. So this is like a rehearsal before you are putting somebody on this device so that it is not risking your health. And this is a randomized control trial, a population of 90 people with type 1 diabetes. And this is an ABC study. ABC stands for Adaptive Behavioral Component, ABC. And there is another component that is Behavioral Adaptation Module. So this can be compared to a self-driving automobile. And let me make a comparison. And ABC and BAM, that is a basic training. And this is similar to you are sitting and then relaxing, sit back and relax, and the car will learn the road. Whereas adaptive behavioral component will train the car's brain so that it will learn the road, it will get familiarized with the traffic, with the shortcuts, and also the favorite routes automatically. So likewise, this is a comparison with the control IQ. Control IQ is the control of the tandem insulin pumps, which are being studied in most of these comparisons. And using a digital twin simulation and a what if scenario, when you are comparing control IQ with control IQ combined with the ABC model, look at the improvements in time in range from 73 to 77%. And even for time in tight range, that is between 70 and 40 has improved from 48 to 52%. All these numbers are statistically very, very significant. And now let me dive into the deeper aspects of the future, and this is the fully closed loop systems. So until now, I have discussed about the hybrid closed loop systems and how we can incorporate the newer algorithms. And this was a presentation that I have also attended, where we discussed about the major obstacle to the development of a fully automated delivery device. What is the major obstacle? What is the roadblock? Is it the insulin pump? No, we are having the best of insulin pumps now. Is it the algorithm? No. Now the engineers working with the doctors are actually so smart and brilliant that they are developing better and better algorithms. What are the sensors? The sensors which are there in the market, the best sensor, the number one sensor now available in the global market is Libre 2 Plus and 3 Plus, and they are having a MARD of close to 8.2%. So these sensors are also very good. And the real roadblock to the development of a fully closed loop system is actually a rapid acting insulin analog. We don't have a rapid acting insulin analog which is rapid enough, and this is how you can work on the pharmacokinetics mismatch, where the AD system is struggling to deliver insulin quickly enough to prevent the post-meal glucose spikes, that is, there is a residual risk of hyperglycemia, and there is always a residual risk of a late risk of hypoglycemia. So I don't know whether we will be able to have a really rapid-acting insulin in the near future, but the technologies are trying to circumvent this barrier. And these are two studies, one in 2021 and another one in 2023, comparing two modalities. We have the USS Virginia, and that is University of Virginia's simulator system. These are all simulator models. And then you have UMPC, that is University of Pittsburgh Medical Center simulation model. One is the USS Virginia is a hybrid closed-loop system, whereas UMPC is a fully automated closed-loop system without meal anticipation module. And when you look at the blue areas, here you can see the glucose is much lower. And comparing the two modalities, there is of course a difference in the TR, which is not at a target, but the hypoglycemic rates, the time below range, is similar with the both the modalities, with hybrid closed loop as well as with fully closed loop system. It is same. So we are very close. And there is another very attractive strategy, that is BPS. BPS stands for bonus priming strategy. I know many of us in our clinics, when we are having insulin pumps and AIDs, we are practicing already a bonus priming strategy, since we are aware of its superiority over the conventional delivery. And BPS stands for, or this is when a small or a tiny automated insulin bolus is delivered the moment a meal is detected. So these are innovations where the system is automatically detecting the meal and delivering a tiny bolus before the delivery of the actual bolus. So these are 11 adults with type 1 diabetes, and this is a supervised random crossover study. And this is FCL at home, fully closed loop at home, AIDA net study, that is automated insulin delivery, where the performance adaptation system, that is performance-based adaptation system, is also being considered. Bonus priming system is there. A temporary control rate is actually considering the changes in the stress, the sleep, physical activity, and so on. There are artificial neural networks, and these are the AI and the deep learning algorithms. A cloud-based monitoring, which also includes remote monitoring for ensuring safety, and adaptive aggressiveness for determining the dose of insulin and aggressiveness for the dose of insulin to be delivered. And this is a study overview, a 14-day home control period on usual care, a 5-day in-hotel supervised fully closed-loop system, and 7-day at-home remote monitored FCL. And the results are pretty very impressive. So when you are comparing with the usual care and with the fully closed-loop system, look at the huge differences. Of course, the time in range, there is a difference. The time in tight range is also statistically highly significant. And the time above range, time below range, all of them are statistically significant. But if you look at the real difference, overall control, the daytime control with overnight control, and this is where the fully closed loop system will be having a real advantage. With overnight control, it is 64.3% versus 76% time in range. So these are the results and the limitations of the study. The AIDA net FCL system achieved non-inferiority compared to the usual care system for almost all these metrics, except there is a significant improvement in the nighttime glycemia. And this is the likely results of automated adjustments without the user input. And the limitations, it is a study of a duration of only 12 days, and this limits the usability and the insights into a longer term. So we require longer, well-conducted randomized clinical trials to assess the real world performance over 6 months to 1 year in a home setting. So moving on to another area, and this is iPancreas, and this is from OHCU, and this is Oregon Health and Science University in the United States, using Dexcom G6. either a Google Pixel phone or a Polar M600 fitness watch. And then you have the Omnipod from Insulet. And you have AWS cloud monitoring from Amazon. And they have incorporated a MPC, that is a model predictive controller, a meal detection algorithm, and then hypoglycemia prediction using LSTM, which stands for long short-term memory neural network. So almost all of them are incorporating the neural networks as well. And the results are actually very, very encouraging. 38% less user-initiated bonuses. So that means the manual interventions were significantly less. User-initiated bonuses were reduced to 38%. And with iPancreas, the TAR was non-inferior to usual care. And the meal detection occurred within 26 minutes on average. So the system was able to detect a meal automatically. And with 83.3% sensitivity, it was actually capturing the meals. So one major challenge is getting actually circumvented. And then moving on to another important presentation. And here it is a AI-enabled dual hormone MPC model, that is model predictive control algorithm for automated insulin using two hormones, insulin and pramlintide. So these are also getting tested. Earlier also, similar clinical trials were conducted, but this time the difference between the earlier clinical trials with pramlintide and insulin and the current clinical trials is with the algorithms. So the MPC algorithm is AI enabled, and that will deliver insulin and pramlintide. And the MDD algorithm is also a neural network algorithm, and that is to detect the carb. So this is the neural network meal detection and dosing algorithm, that is MDD. And this will also trigger the insulin dosing. And then you have the insulin and the pramlintide MPC core algorithm. And this uses a novel pharmacokinetic pharmacodynamic model for delivering pramlintide, and this is based on human meal challenge data. And there were three strategies for delivering pramlintide. One is as a fixed dose, and the second is basal only, a constant rate, and the third is independent delivery of pramlintide and independent delivery of insulin. So if you look at the results of these studies, in the usual scenario, only using insulin, it is 64% time in range. And when you're using a pramlintide at three different strategies, it is close to 90%. With lower peak glucose spikes post-meal, because pramlintide will address the post-meal hyperglycemia, and the hyperglycemia also remained at safer levels. But the major challenge is these are primarily simulator-based working models. We need larger scale clinical trials, and the dual hormone device developments, they are very complex. The regulatory requirements also very complex and stringent. And pramlintide, unlike insulin, it can also result in some adverse effects such as nausea, very commonly seen with amylin analogs. Then a word about the adjunct therapies. And these are either metformin, DPP-4 inhibitors, gliflozins. So there are many clinical trials where they have used non-insulin therapies for type 1 diabetes. And now there are even recommendations on how to use it. Of course, these are off-label. No recommendations are there from any scientific bodies. And this is with liraglutide long time ago, adjunct 1 and adjunct 2 in type 1 diabetes. So when you are incorporating a GLP-1 based therapy, for example, semaglutide or tirzepatide in AD systems where the people are using this for type 1 diabetes care, this is a rough guidance which appeared in diabetes therapy. You may have to weaken the ratio of ICR. You may have to increase the active insulin time to 3 to 4 hours. And this is in Minimed 780G. And this is meant for minimizing the hyperglycemia, since the total insulin requirements will come down with the use of these therapies. So, of course, this happens even in type 1 diabetes. And when you are using DEPA-REMBA, again, the total daily dose of insulin can come down by 20 to even 35%. But of course, this has to be individualized. Sometimes there may not be any change, but in many people with type 1 diabetes in adults, there can be a substantial reduction in the total daily dose of insulin. And I have only 2 more slides to go. And this is with the patch pumps for the future with Beta Bionics. Tandem, Medtronic, and others are developing tubeless patch or Mobius type devices, tiny devices. But the future is focusing towards the patch pumps. And then Abbott is already there in the clinical trials, and in 1 or 2 markets it is available, the dual glucose ketone CGM systems, where in the same mobile phone app you'll be able to witness not only the continuous glucose monitoring data, but also the continuous ketone monitoring data, which will get integrated in the future AD platforms. And this will be the future. No meal announcement systems. There can be dual hormone systems, adjunct therapies with GLP, SGLT inhibitors, amylin analogs, along with the automated insulin, because automated insulin delivery is the standard of care in type 1 diabetes. And then more and more wearable patch pumps and tiny tandem mobile-like devices and dual sensor, which can sense glucose along with ketone or other parameters. So let me invite all of you once again to RSSDI at Kochi in Kerala in the month of November. And thank you, Dr. Benshi, Dr. Manoj, Dr. Amit, and my friends for giving me this opportunity. Thank you very much.
Thank you very much, sir, for the wonderful comprehensive deliberation on this latest technology usage of automated insulin delivery system, especially in the management of type 1 diabetes with the multiple insulin usage. And you've given the great clinical insights on the recently launched Liberate to ICGMs, especially ICGM, is integrating both our closed hybrid loop as well as the CGM. One of the useful messages, sir, on the entire mechanism and the entire journey of automated insulin delivery, right from semi-loop to hybrid loop and closed loop system. Thank you very much, sir, for the wonderful deliberation.
Jyoti, what do you feel that the future of AID in India? I mean, we know that a lot of things are happening around the world. Bionic pancreas, now Marbidol, they have made a song with bionic pancreas, not even the AID. They want to go for advanced hybrid closed loop to fully closed loop system. But what about the India? Are we going to have patch pump in India? Are we going to have the pump which are along with other integrated CGM system? What's the future of AID in India?
Benchipai, I think the future of AID, India is looking for a cheaper device since many of the patients and even the government cannot afford very expensive devices as an automated insulin delivery. So we may be probably soon having a pump which is affordable, but that is going to be a tethered pump, unfortunately. But in another 1 or 2 years' time, we may be in India, we probably will be able to develop a patch pump which is affordable, or a tiny pump which is similar to a patch pump. And now creating AID is not a big deal. So if you have a ACE pump, that is a pump which can connect to any sensor, then it is easy to develop a automated insulin delivery based on a patch pump which is developed from India. I think sensors need not be developed in India. Sensors, cheaper and accurate sensors may be soon available in India. And the currently available Libre 2 Plus is also relatively cheaper when compared to the earlier sensors used along with the AID. And the future devices, even though we are developing a tethered pump, the patients will be again requesting for a patch pump. Because when you compare the comparison of a tubed pump, when you compare with the tubeless pump, the convenience is so different. So patients who are used to a patch pump, even though the algorithm is inferior, that is a fact. The Omnipod is having a algorithm which is far inferior when compared to Minimed 780G. Still, people are opting for that, even if the time in range is around 65 or 60%. Still, many people around the world, they look for an Omnipod because only for its convenience. So when Dr. Benshi Sabu and the team is trying to develop a insulin pump or an aid in India, I think we should also be looking for a patch pump. No, I am serious. I am serious because I know you are and all of us are trying to develop something for India. I think we should be aiming for an automated insulin delivery where we can incorporate a patch pump.
Great.
Yeah.
Any other question?
So any future direction for this one usage of AID in type 2 diabetes, sir?
You mean in type 2 diabetes? Because now
There
we
was
are
a dedicated session in JPF here kept, other than AI, uses of AID in a specific situation. Yes, Jyoti, you please
yeah.
answer.
There's a dedicated session is there. Was there? So, Kannan, it is an excellent question. We have to go by the recommendations from RSSTI, from ADA, from ISPAD. So there are specific recommendations in any type of diabetes. We can use it because in type 2 there will be 2 to 5% of people who will not respond despite GLP-1, despite uh, insulin, basal bolus insulin therapy. They might not respond. So these are people who should be instantly put on automatic insulin delivery. So I always used to say that in 2025, there is no diabetes which should be described as uncontrolled diabetes. Any diabetes can be controlled, and this can be controlled either with the older or a newer therapies or with a combination. And whenever it is possible, you have to pair it with technologies, and then the success is 100%. Yeah.
So in the complete closed loop systems, you have mentioned about the dual hormone, that is one on amylin and the other is insulin. What about the usage of glucagon in that closed loop system, sir? You mentioned the amylin and insulin.
Yeah, there are a couple of systems where glucagon is also being tested. And even in the initial system tested by Damiano, that is Beta Bionics, they had a bionic pancreas where they were having glucagon. And the recent ones, they are using the DESI glucagon, which is more stable when compared to the conventional glucagon. But Heather and the group, they did a meta-analysis and they found that the difference between insulin only and insulin along with glucagon systems, uh, the difference in time in range and the hemoglobin A1C, it was not statistically significant. So when we are having better algorithms and better continuous glucose monitoring sensors, you may not require glucagon. That is what they found. And
Yes,
in addition, when you're using glucagon, you have to have two infusion sites and you have to have two different sensors. But the one that I have shown with pramlintide and insulin, they are actually having the same infusion site and they were
yes,
using the simulator models. So that is the difference. So they were having a fixed ratio. That is not possible with glucagon and insulin.
sure.
So we may not require glucagon. That is my understanding. That is why I learned. Maybe there are still some clinical trials going on.
Thank you, sir.
Thank you. Thank you.
So now we can invite Kanan.
Yes, sir.
Manoj, you are ready?
Yes, boss.
Okay. So,
So,
Kanan,
friends,
please
we
introduce
go
the
on to
program.
the next important topic on CGM. Friends, we know that the CGM is making a revolutionary in the management of type 1 diabetes as well as the type 2 diabetes. And it has been entitled as the gold standard and become the standard of diabetes care as per by all the societies, including AD and EST. But it has its own fallacies, including the challenges and controversies. To talk on these controversies in CGM, we have our own friend, an eminent speaker, Dr. Manoj Chawla. He's a global speaker. He's a MBBS diploma in diabetology. He's a FRSSTI. Sir is a director and consultant diabetologist, Lina Diabetes Care Center. He's a consultant diabetologist at Induja Hospital and Rakesh Hospital. Organizing chairman Diabetes India 2025 and scientific coordinator RSSTI 2023. The elected All India Executive Committee member RSSTI 2022. Scientific Chairman Diabetes India 2023, is Organizing Secretary Diabetes India 2022, is Honorary Visiting Faculty of Patel Medical Sciences, NABI, Mumbai, and awarded as the RSS Fellowship and Fellowship of the Royal College of Physicians of Edinburgh, and Principal Investigator of
my dear
various
Kanan. Thank you.
technology task force member, and so on and so forth. These are lot of accolades to be encountered. And over to you, Manoj sir.
Thank you, Kanan. Thank you, Dr. Amit Gupta, Dr. Banshi Sabu, Team Diabetes India, for asking me to speak on one of the topics I understand a little better than others. In the sense, other topics. So after listening to that wonderful talk by Dr. Jyoti, they're taking us through the journey of advances in AID and what the future holds. I'm going to have a very short talk on controversies in CGM. This topic was actually covered by the ADA, and they covered two aspects of that. One was looking at the TIR versus HbA1c, and one was looking at the GMI versus HbA1c. Now, I thought I'll bring about more general limitations and controversies in CGM rather than sticking to those topics. This is what may be relevant to our Indian physicians. So I will start sharing my file and talk about that. So Pratik, the haircut suits you very well, makes you look really, really martial and sharp. So congratulations on that. Right. So I think I got my presentation in place and I'm gonna go full screen now, right? Somebody can help me.
Yes,
My
yes, sir.
screen is seen, right? Okay,
Yes,
great.
sir.
Let me pause, get going on the controversy. So, well, so this is, we start on CGM. What is CGM? Let's always remember that it's a mean of tracking sugar levels. It measures interstitial fluid glucose on a continuous basis. A very, very old slide, but it still gives us, even though the CGMs have evolved, the portions of the CGM, you will have a transmitter and you will have the small silicon fiber tip going into the interstitial fluid and measuring the interstitial fluid glucose does not measure your capillary or whole blood glucose. So that's important to remember. And which is where a lot of limitations and also controversies arise. CGM provides us a visual feedback to help the patients themselves and clinicians understand the variability. And as we can see here, and we've known, just an HbA1c may not suffice. People may have similar A1Cs, but completely different glucose profiles, one acceptable and one harmful. And which is where it's important to see the larger movement of sugar in the whole picture. CGM is beneficial for everyone who wants to monitor their diabetes, somebody with diabetes, pre-diabetes, a health fitness person, and so on. Having said that, especially more beneficial in people who are not meeting their A1C goals, have frequent lows, are unaware about their low sugars or the variability, want to reduce their A1C target, but not at the cost of hypoglycemia, high variability, and of course, children or adolescents who are willing to use the device every day, of course, the ones with type 1 diabetes. Well, important to remember, look at the nomenclature. What are the nomenclatures? You have real-time CGM, which is one which shows the data on a real-time continuous basis. You do have intermittent scanned CGM, and which is what has been used largely in the recent years in India. You've had the Abbott Abbott Freestyle series, which is the intermittent scanned one. Of course, Dr. Jyoti, they've showed us that we are getting the real time, or what is called as iCGM, which is the integrated CGM, which will be real time, which is the Freestyle Liberate 2 Plus, was launched at Trivandrum at JPEF over the last weekend and should be available for use to all of us in the coming weeks. You also divide CGMs into professional or blinded CGM, which is what was used a lot in India earlier. Unfortunately, not available predominantly from Abbott's side. And then you also have over-the-counter CGMs, which have a narrower range, which have been available, and you have two or three different products, especially in the Western market, available as over-the-counter CGMs, which are not for people on insulin, which may not be the best to detect hypoglycemia, but a certain range, in some from 70 to 250, in others from 40, 50 to 200. So you have different CGM ones over the counter for markets where you can get it without prescription. Of course, in our country, all these CGMs are available easily without prescription. So over-the-counter ones probably don't make sense here. We look at the MARD and accuracy. So one of the first limitations or controversies comes from the fact, how accurate are these devices? Are they really accurate? Can we trust them? So for CGMs, the the MAD, which is your mean amplitude of range development, the deviation ranges from anywhere between 9 to 12%. In fact, the new one that Dr. Jyoti spoke about has a MAD of 8.2%. So MAD is your metric of accuracy. The MAD is worse when the blood sugar is low. So small absolute errors are large percentage errors. It's something for us to remember, and I'll show you a grid which explains that. So when we say about, oh, it's a small percentage error, but then that actually can have a lot of difference. When glucose is changing rapidly, The lag period, which has now been brought down to just a couple of minutes and earlier was 10 to 15 minutes, was a problem where after the meal, you may check the sugar and on a glucose meter, it is showing 210, whereas on your CGM, it may be still showing you as 155 or 267, depending on what phase you're seeing. And of course, on the first day of wear, the MARD may not be the best. So when you have products approved, you see MARD as an overall value, but not the actual differences which on a particular day may have an impact on the accuracy. As we explained, small absolute errors can be large percentage errors, right? And each of these can be into 10 milligram percent and multiplied onto the same. Now, there can be also a problem with inter-unit and inter-manufacturer variability. And this was the data presented at ADA by Fruckman et al. A good study participants wore 2 units from the same manufacturer, right? Or 2 or 3 units from different manufacturers. So you're trying to look at that, every time patients would say, we've compared and matched. So this was a study where you take two, let's say you're picking up Abbott once, you're taking 2 sensors and wearing and seeing the data coming from both of them. What is the variability? And then I'm wearing 3 different sensors from 3 different makers to see how things are going haywire. The objective was to analyze the differences in continuous glucose monitoring derived metrics among 3 current generation systems and evaluate their impact on therapeutic decision making. 23 adult participants, 14 days, Freestyle Libre 3 or Dexcom G7 or Medtronic Simplera. So 3 of the better accepted CGMs were used. And what you can see is clearly a difference. You're looking at Freestyle Libre 3 where you're getting a TIR of 76.3. Dexcom G7 pretty close to it at 76.2. In the Medtronic, you're seeing a TIR of 84%, whereas even the TBR is higher in the Medtronic at 5.1. So you can see difference in glucose profiles between different approved and validated makers. So CGM systems indicated discordant glycemic metrics that should be considered in diabetes therapy, and that's where the controversies arise from in terms of CGM. Also, when we look at the GMI, which is glucose management indicator, now GMI has a formula, the same way that your interpretation of HbA1c in real world today when we use HbA1c, how do you explain what an A1c of 7.4 is? So you may say 7.4 is, let's say, close to somewhere around 173. But how did you get that figure? It's an arithmetic calculation. Similarly, for GMI, you have a calculation based on what you're seeing on the CGM. But look at the differences. From different manufacturers, you can see such a huge variability, which we showed you already in the previous one. And the same is applicable for glucose management indicator, which has actually replaced the estimated A1C on your CGM readings. So there can be variability leading to problems. GMI versus A1C discordance was discussed at the ADM. And as I said, what is GMI? It's a glucose management educator calculated from an equation that translates mean glucose from a CGM into an estimated A1C value. The problem is that in individual patients, GMI performs poorly as an estimate of A1C. The idea is when you're looking at CGM, let's focus more on the TIR metrics, which are simpler to understand. But somewhere, the entire concept of CGM and the makers of CGM and the experts in the field of CGM globally have felt the need to give one figure. So earlier they gave estimated A1C, which had its own limitations. Now they have come with GMI, which is a figure which actually comes in values closer to the A1C for better understanding of the population, but has its own limitations. So some of the proposed solutions are stop reporting GMI, and I'm completely agreeable to that. Relying on CGM mean glucose and TIR rather than looking at GMI, and using CGM mean glucose and lab A1C in tandem may actually help rather than looking at this GMI or estimated A1C, which can completely be misguiding. There is also some lack of complete consensus on CGM use in non-insulin treated type 2 patients. A growing debate all over. Though purists like me, Dr. Jyoti, Dr. Banshi, Amit, Supratik, many of us here, and Kanan, would strongly believe that you should not deny anybody the ability to monitor, especially in a self-pay market where it's not the insurance who's paying for it. So the benefit, the point of debate has been on cost versus benefit. Well, the point there is CGM are expensive, but on the other side, blood glucose monitoring is may not be adequate. So on patients on insulin, is it really needed? Keeps a question. Limited guidelines. So earlier, the ADA guidelines did not explicitly endorse CGM for non-insulin, causing hesitancy. Today, it recommends that yes, for everybody with diabetes, CGM may be helpful. There are insurance denials and, of course, clinician inertia in understanding the benefit of the CGM, or rather understanding CGM completely, which is why I'm happy to announce that just today that we have let out our first major announcement on the start of RSSDI CGM clinics, which shall explain the basics of CGM, better understanding, sharing of CGM graphs with some case background there, and quizzes based on CGM towards better monitoring and better understanding of CGM. Moving on with the controversies and limitations, one is the alarm fatigue and data overload. So for people who are using real-time CGMs, very often they just switch off the alarms and then they miss out on the alert. So having alerts is important, but also to be aware that too many alerts and alarms can lead to the fatigue. There is a lot of data flowing in, so data overload can be overwhelming, and hence, rather than just encouraging over-the-counter use of CGMs for our patients, it's important that clinicians get trained and guide their patients on what CGM to use, the frequency of usage, the interpretation, when to react, when not to react, so that they continue to use it to uh, uh, um, their help and do not feel guilty, stressed, disengaged, or there is too much of burden either for the physician or from the patient from the data which comes in. Moving on, some of the other controversies come to the accuracy, and there will be times when patients will send you images like these, like we used to get in the past, that see the disparity between the CGM reading and on the glucose meter. Well, when we said there can be multiple reasons. This could be day one, there could be a lag period, this could be happening soon or after a meal, or there could be genuinely a problem in that CGM sensor which is not being very accurate. And these kind of comments, sometimes the patients have sent us that this is showing low, but I am fine. According to this reading, I should be dead by now because it's showing low, but my actual glucose meter reading is 124. So it becomes difficult for the physicians also. Also, let's remember, just like A1C, substances and factors may affect CGM. Any higher use of acetaminophen, more than 4 grams per day, can affect the Dexcom values. Any dose of acetaminophen may actually interfere with the Medtronic Guardian sensor. Ascorbic acid, more than 500 milligram per day, and we use it a lot for heart patients, can be actually affecting your Libre series, high sensor readings and actual glucose when there is ascorbic acid used. More than 1000 milligram per day of vitamin C or ascorbic acid can further create problem. And then interference in from substances like hydroxyurea, mannitol, and sorbitol in special circumstances. There will be limitations of CGM in critical care. It's not really approved. It's been more off-label use at places. The lag time issues may get more relevant in an ICU setting. So you have to, where in doubt, then cross-check. Also, inadequate correlation in special conditions when you have hypoalbuminuria, a lot of fluid or generalized edema, or in patients with hepatic failure, we do not have much data and accuracy on differences between blood versus interstitial glucose. So those are other concerns when it comes to the ICU. There can be device-related challenges. Well, glucose, the sensor not coming off, it's there, but it is not showing you the data. The reaction or rashes because of the sticking adhesives, or sometimes the bruising by a sensor, as you can appreciate on the side, and can get painful. Rare, but it can happen that once in a while it hits a capillary and it can create problems. So though we largely speak about the benefits of CGM, today's session has been to discuss more about limitations and controversies where you've started the sensor, but after that time it is again saying it is not started, keep checking, and very often the sensor gets wasted. terms of bruises, sensor errors, and so on, which continue to plague the wider use of CGM. So we really hope that the CGMs really improve from here. Let's remember it's a powerful tool in diabetes management. It does come with own challenges and controversies. The key concerns include accuracy, high cost and affordability barriers for a country with 100 million people with diabetes, but affordability being limited, it is a concern. For the ones who are using regularly, then there are problems with fatigue from the alarms and data aspects. Well, let's understand that CGM is an ally to everything that we do for diabetes management. It's not a solution in itself. Clinical use must be personalized based on the patient's needs. Emphasis on educating both the patients and providers is crucial, and this is Diabetes India's initiative to continue to educate clinicians in the field of monitoring and diabetes and giving you both the perspectives. There is a need for better advocacy, and as we adopt CGM more widely, we must balance innovation with caution and be aware of limitations of each technology as we move ahead. So with that, let me thank you and hand it back to the chairpersons for any question answers that may be there. Hi, Sanjay.
Hi, Manoj was listening to your talk. Thank you for getting this controversies. Every time we're only talking about benefits of CGM. I remember 3 years ago, they asked me to debate against Rajiv and saying use of CGM for type 2 diabetes. And there was no data and consensus. I'm glad ADA has come back with something and say it is useful. We all know it's useful.
Sanjay, I'm
for
glad
people.
this topic was given to me because I didn't even have a sponsor for CGM, so it's better that I speak about the limitations.
No, I didn't have a sponsor. It was a purely academic talk, and I had to battle like a lawyer, telling diabetes doesn't mean it's one factor which is responsible for blood glucose. I found out there are 42 different factors when it influence blood
Wow.
glucose.
Wow.
So when we're looking at all of this, I think CGM has a place in every type 2 management of diabetes, whether it's type 1, we know they're very useful. Type 2. Thanks for getting all these controversies, the lag time, the different problems when CGM readers or the things which don't read. I think with newer technology, but I'm still concerned. The MARD is not really gone closer. Even with the newer ones, the MARD is around 8.2 to 10.
So Sanjay, actually an 8.2 is great. You're aware that the FDA is asking for anything less than 15%.
Yeah, less than
the
15.
other aspect is
I see with improvement in technology. I know less than 15 MARD is, but I was looking 8 to 12, 9 to 12, the earlier CGM 8.2. I think we'll get there probably by 4 in the
but
next
it's
couple.
not the improvement on MARD, Sanjay. Actually, it says that MARD is not always sufficient to look at. So there are other aspects going
Other
beyond
aspects of
MARD.
it.
And as I said, and Dr. Jyoti also probably mentioned that it's not always going to be just MARD. I mean, you may have a MARD of 8, 9, but you may still have point zones where there is
Yes.
a huge difference, and it just averages up for the accuracy.
Yeah.
But at a given point, you may have sugar differences which are 50.
Oh, they can be very huge. This is what that huge sugar differences which you showed. My idea is trying to talk to the patients, telling them you're looking for trends, not for the exact value at every point of time would make a lot of sense in terms of educating the patient. Sometimes they cross check and then you find this lag time and the difference between SMBG and the point of reading at that point at CGM. That is what puts off people in terms of they're saying, oh, the accuracy part of it. Probably educating them better would make a lot of sense when we use them. We all use them. And thank you for getting all these controversies, Manoj.
Thank you.
I think we'll get better. We'll get better over the days. I think 10 years, 12 years down the lane. I think everything changes. Yes. Thank you, Manoj.
Dr. Manoj, can I make a comment? Because
Yes.
Dr. Tade Bachelor always used to say that A1C is dead. But in your statement, you were actually going back to the A1C. It feels as you have to still keep on using the A1C, but A1C has also got multiple limitations.
Yes, sir. Everything has.
Yeah, everything has. But so in between A1C and the TAR and the CGM, how will you make a recommendation to your doctors? So can they use the CGM devices for accurate determination of TAR? So do you believe, Manoj, that in the future, in another 5 years or so, the A1C will be completely replaced by the new metrics?
So, as of now, what I do, Jyoti, and I don't know how right that is. If I'm looking at A1Cs and the A1Cs are not in the target range and a 7.8, 8.2, whatever, and we start looking at CGM profiles, which clearly are showing variability and a lot to be desired, including the TIR. So while we are trying to make improvements, I would still in the future continue to monitor the HbA1c and look at the CGM metrics as and when the patient is doing it. However, in somebody where you identify a disparity that somebody's A1C is at 8%, but the previous 30 days and 90 days TIR is largely at 75 or 78% with no TBRs, and you've also noticed some disparity in SMBG and A1C values in such an individual in the past. For that select population, I may stop relying on HbA1c if they are doing
Yes.
these CGMs regularly. So it is still early days to say that we can completely knock off the A1C. Tade is far more passionate than I am, and of course he has more infrastructure and means at his hand to be able to use it and offer it to all patients. But having said that, for us, I think we will still continue to use it. It's only in a select population where you are doubting and clearly seeing evidently that the A1C is not matching up to the TIRs, and it's going to be a waste to look at the A1C. In some of those select patients, I've told them, let's not bother about your A1C, because that's not going to tell us where we really are.
Yeah.
But for many others, we may still continue to do it for the strong evidence it has.
I think
I absolutely agree with you. We need to have more data than we. Yes, select populations STIR would become better than relying on HbA1c, but not a generalized statement. But making better therapeutic options, especially deciding the type of insulin, many things. I think the trends help us help us and the patient for better
Absolutely.
therapeutic options.
Sanjay, one of the important places you'll agree is giving the courage to physicians to decide on the change in time of
Yes,
medications.
yes.
Whether it is insulin, whether it is any other tab. So often
Many
now
other.
we are using it just with tea and two cookies, because by the time otherwise at breakfast the sugar is going up to
Going on.
180 to
No,
100.
no. What we do as a practice now is, if I want to start insulin on a patient, I'm just say use this. Come back after 7 days. Let's just look at it and then decide what type of insulin I want to use for it.
Absolutely.
It makes a lot of
Absolutely.
sense before starting, and it's also easy to convince the patient to say, okay, he doesn't want to take insulin. Just look at your trends. Let's see what's happening, and come back, and then we decide what best type of insulin. Rather than just looking at a couple of values and telling, okay, you're going to be better with this particular insulin regime. I think that makes a lot of it makes life easy in trying to choose the right therapeutic option for the patient. That's all I can say.
Manoj, I have a question. See, we have the disparity on the lag period because we are seeing the CGM is interstitial fluid rather than the plasma glucose. But in case of acute events like hypoglycemia, level 1, level 2 hypoglycemia less than 50, so the recommendations are given even with the irrespective of intermittently scanned CGM or real-time CGM. The recommendation given to use the SMBG with these patients. How we can overcome? What are the take-home message for our audience here?
So, no, I think that still continues to be an issue. If your symptoms are that of hypoglycemia and your CGM is showing a lower value, then you might as well treat that. But if you are absolutely asymptomatic and your CGM values are not matching what the time of the day or what the expectation is, it may still be warranted to cross match. There are many who said that stop looking at SMBG, but I think till the time that at least we get our hands on far more accurate CGMs that somebody can vouch for, no batches which may have its own accuracy issues, we probably in those circumstances ideally still should be doing an SMBG to get the accurate reading that time. I know having said that very often raises the question, then what is the purpose? We are losing the purpose at all of using the CGM. But not everybody is going to be dropping to 40s and 50s. Very often it is to look at the trends, the peaks, and of course pick up the direction of going into low. But when in doubt, it still may be pertinent to try and cross check with an SMBG if the symptoms and as I said, the timing and expectations are not matching what you are seeing on your CGM value, rather than react to it without confirming and lead to other consequences.
Thank you.
Thank you, Manoj.
Thank you, guys. And we now, I guess, move to listening to Supratik, who's been waiting patiently.
Yeah. So, Pratik, thanks for waiting. Please go ahead. So, Pratik is an endocrinologist from Calcutta.
So
Over to you.
yeah, thank you to Dr. Bansi, Dr. Sanjay, Dr. Amit, and thank you, Dr. Kannan, for holding it together. And it's an absolute pleasure hearing Dr. Jyotidev and Dr. Manoj. My disclaimer is I'm not a very techie person, so I'm taking this, on board, and I'm using it as a tool when it comes to clinical practice. Hopefully, I'll get better at it with the use more frequently. That's where I stand. So I'll take 1 second to, upload my slides. Just give me a second. Um, Am I still audible at the moment?
Audible, yes.
Audible. Also audible, Supratik.
Okay. So this is exactly what I was saying. How do I go about it? Just 1 second. What can you see? Is there anything that is
Only we're able to see in your desktop only.
Yeah, you can click on the PowerPoint. PowerPoint is at the bottom.
right? Perfect. Yeah.
Yeah.
It has come.
Thanks. Yeah. So yeah. So I'm going to talk about the best means of measuring hypoglycemia. So this is going to be my, the learning objectives for today. Understand the symptoms and severity. Go on to explore the methods of measuring hypoglycemia. Compare accuracy and clinical utility, and review the latest evidences and guidelines coming in from ADA 2025. And now, definition of hypoglycemia: plasma glucose going below 70, and then clinically significant hypoglycemia when it goes below 54 milligrams per deciliter, and then obviously a severe hypoglycemia, meaning warranting third-party assistance, as comes from the ADA 2025 classification. So, sitting with the patient and taking a robust history is very, very important, because most of the hypoglycemic episodes can be identified by just talking to the patient, and the most common symptoms, as we know, can be hunger, fatigue, drowsiness, dizziness, restlessness, and then the autonomic symptoms will usually precede the others, like sweating and tremors visible, and sometimes it's very vague symptoms that they come with, and you just need to identify their meal patterns, etc., to understand that probably they are having hypoglycemia. As you progress farther down, you can have the cognitive and behavioral changes like confusion, difficulty concentrating, headache, personality changes, cognitive dysfunction. And then progressing further, you can have neurological symptoms like blurred vision, speech disturbances, motor incoordination, leading on to fatalities like seizures, coma, and even death. Now, the concern is if somebody is living with diabetes for many number of years and relatively uncontrolled, they can also have, hypoglycemia unawareness, which is related to the autonomic dysfunction. So this is something that you need to understand very carefully and intervene. And I think this is one of the places where the latest technologies like the CGM based approaches can work very well. Now, measurement modalities, as we said, just going back, we have the capillary blood glucose testing, venous plasma glucose, continuous glucose monitoring, and the flash glucose monitoring. So The capillary blood glucose, to start off with, is a point of care device with a glucometer. It's fast, relatively inexpensive, but variability based on technique and hematocrit, and accuracy, as we see, can vary up to 15% depending on what brand you're using and how accurately you're actually calibrating the device. Coming to venous plasma, again, depends on the lab standard, usually collected in tubes which prevent glycolysis, like sodium fluoride or sodium EDTA. Now, the reference method that we use is hexokinase method, which is the gold standard because of the high specificity and less interference. Less commonly used are like the glucose oxidase, and the other one we don't use at all. So not suitable for real-time decision making, because when it comes to an hypoglycemic emergency, you need to fall back on things like a glucometer, and we'll talk about it as we go on. So continuous glucose monitoring, it can be real time, as we have the Libre or the Libre 2, or the retrospective data that we had been talking about with Libre Pro, which is being gradually phased out at the moment. And the concern is, the sensor is in the interstitial fluid, and there's a lag time, and it measures glucose every 1 to 5 minutes. Flash glucose monitoring means something like the Freestyle Libre. And again, just to sum it up, real time, but no alarms in Libre 1. You have alarms with Libre 2 that is coming up, and retrospective with the Libre Pro, which is now being phased out. Intermittent monitoring by the patient is warranted. So this is a quick comparison between Libre 1, Libre 2, and Libre 3. And you can see in here, Libre 2 and 3 incorporates the real-time alarms for hypoglycemia, which was not there with Libre 1. Scanning or flashing is required with Libre 1 and 2. Libre 3 doesn't warrant that. So FDA approval with Libre 2 and 3. And it can be linked with mobile apps. And key studies, as you can see, with Libre 1 was impact, Libre 2 was replaced, and then Libre 3 real world data. MARD, mean absolute relative difference, Dr. Manoj was talking about, and Dr. Sanjay subsequently, that we are getting better and better. So if you can see in here, the MARD has gone down from Libre 1, it was around 11.4%, going down to 9.2% with Libre 2, and finally less than 8% with Libre 3. So glucometer could give you a MARD of 9 to 15%. CGM, Dexcom, which we don't have access to at the moment, has 8%. And flash glucose monitoring is about 11%. So lag time in interstitial versus the plasma glucose is one of the concerns that we have with the CGM devices. Real-time alerts reduce severe events and useful in nocturnal hypoglycemia, which is otherwise missed with with the self-monitoring of blood glucose with a glucometer, and this remains one of the the beauties of CGM, that we need not scan at the middle of the night. You get a trend, and if you have an alarm, you get an alarm as well when the sugars are going low. So helps in detecting asymptomatic hypoglycemia. Now, there are HypoDE study which shows that CGM reduces severe hypoglycemia. Alert 1 had shown that it improved time in range, and mobile study CGM use in primary care. Now let's come to the ADA 2025 recommendations. Use CGM in high-risk type 1 and insulin-treated type 2 individuals. Individualize based on the hypoglycemia risk, and encourage patient education and training, which is very, very important. Now, these are the recommendations from ADA 2025. It says, so there's a change in paradigm, as we had been talking about. CGM is now considered the most effective tool for detecting hypoglycemia, especially asymptomatic or nocturnal hypoglycemia, and is recommended for individuals on intensive insulin therapy or with impaired hypoglycemia awareness. Why CGM? Because it's got real-time data, so it detects falling glucose before actually the symptoms appear. It gives you hypo alerts. It shows you trend arrows so that you can intervene. Nighttime detection is one of the strong points. It detects hypoglycemia during sleep, which is otherwise missed. And time below range, it tracks the time below range, and data sharing with the caregivers or physicians is also feasible. So what are the ADA standards of care and that came out from the consensus that the time below range less than 70 should be less than 4%, less than 54 milligrams per deciliter, or level 2 hypoglycemia should be less than 1%, and the variability should be less than 36%. So other detection methods which are now considered slightly suboptimal as compared to the CGM would be the finger stick or the SMBG, which gives you intermittent readings and misses out asymptomatic or nocturnal hypoglycemia. Venous plasma glucose are accurate but not practical for routine use because of the time lag, and symptoms-based detection misses impaired awareness or nocturnal hypoglycemia. So this is the summary table that has been put out by ADA 2025, that CGM or the real-time CGM are highly accurate, detects asymptomatic hypoglycemias. It's recommended by 2025 ADA, and it's the gold standard for detection of hypoglycemia. Intermittent scan again has moderate accuracy and can detect some of the symptomatic hypos. It is recommended by ADA, and the Libre series is an example of that. SMBG, it's recommended by ADA only if CGM is unavailable, and we said that it fails to identify asymptomatic hypoglycemia and also has limited use in nocturnal hypoglycemia. Venous plasma glucose, it's not very practical, but it detects asymptomatic hypoglycemia. And symptom-based, again, although we need to have a robust history in place, but that needs to be sort of supplemented with the other methods as well. So use in special populations, elderly, CGM prevents falls. When it comes to cognitive issues as well, it has a role because if you have concerns, or the visibility for that matter, where you have to prick yourself. Pregnancy, it leads on to dietary control, and CGM is considered beneficial. And renal impairments, where in general the action of the drugs or the insulin is prolonged, it can prevent prolonged hypoglycemia to begin with. Now, what is a better option when it comes to hypoglycemic emergency? And this is what has been asked by Dr. Kannan, and which one is better? So when it comes to hypoglycemic crisis or emergencies, you have to fall back on glucometer because of the high, accuracy during hypoglycemia, and because of the lag time that we had been talking about, which remains one of the limitations of a CGM. And then, it's considered gold standard for immediate confirmation. It's easy to use within 5 seconds, used for treatment decisions or emergencies. And in general, CGM shows a trend, but when it comes to actually detecting hypoglycemia and taking a treatment decision, I think we have to fall back on capillary blood glucose with a glucometer. So limitations of each method: glucometer, it's operator dependent. CGM, the lag time, cost, calibration needs. Flashing, again, lacks real-time alerts, which is now being incorporated with the newer sensors like Libre 2 and 3. Future technologies, non-invasive glucose monitoring, that can be as as a lens or a device like pulse oximeter, but they are non-validated at the moment and not available for our use. Multi-parametric sensors and AI-assisted prediction of hypoglycemia, again, might be useful for us in terms of treatment decisions. Practical tips for physicians: combine methods for safety, train patients in interpretation, and focus on reducing level 2 hypoglycemia, or any hypoglycemia for that matter. To summarize, CGM is best for detecting unrecognized hypoglycemia, asymptomatic hypoglycemia, and nocturnal hypoglycemia, and are strongly being advocated by ADA like bodies for the obvious reasons that we talked about. But in case of hypoglycemic emergencies, you need to fall back on capillary blood glucose monitoring with the glucometer. Choose tool based on the patient, cost, risk. So you can use multiple tools if you need to optimize. Training is critical, and also, as we said, in hypoglycemic emergency, glucometer readings are still considered the best. It's up to you to decide what you want to take on board, but I think combining everything together would give you the best results. So thank you, and I stop sharing now.
Oh, thank you very much, Supratik, for the wonderful deliberation on the hypoglycemia measurements. Especially, you entitled the importance of CGM, and also you entitled the importance of SMBG also. Even though the CGM is a gold standard and advocated various bodies, including AD and AST, but we know that the hypoglycemia is belong to the category of acute emergencies because it may precipitate the underlying cardiovascular morbidity mortality among the elderly population. So any patients with hypoglycemia unawareness, because ADA given the consensus on the impaired hypoglycemia awareness only, but not on the total unawareness of hypoglycemia. So the total unawareness of hypoglycemia, there is total cutoff of the autonomic response, and there will be only neuroglycopenic response, and therefore there will be no counter-regulatory hormone responses in this was unawareness. So this SMAG is one of the gold standard, and comparing with the CGM in acute cases of hypoglycemia, those having the hypoglycemia less than 70 or level 1 hypoglycemia with not impaired hypoglycemia, but it's unawareness hypoglycemia. That is the take-home message given by Supratik. Wonderful, Supratik. Thank you very much for the great learning. Thank you very much. Any questions from the audience or any questions from the our stalwarts?
Thanks, Supratik. That the biggest problem is hypoglycemia unawareness, or HAF, what we call. I think it helps a lot if you have patients with or on CGM on this. Thank you very much.
Thank you
Super.
so much.
But Supratik, is still the awareness for hypoglycemia in India is very less, I can tell you. And see, today topics which we have selected, they are all very important from Indian point of view. The future of AID. At present, we have only 7 ATZ. We wanted to understand more controversies which are in continuous glucose monitoring, because technology space, I think there's a lot of, still gray area for physicians. They don't want to use it, accept it, and sometimes they feel that it is not for them or it is not for their patients. And similarly, hypoglycemia, very important and unrecognized or less commonly talked by physicians for their patients. Even I understand the quinolones dysglycemia is also very common in our patients, but somehow either it is not detected nor reported, or we don't have any data for our patients too. Even the uses of sulfonylurea may be highest in the world, but still, if you see, we don't recognize or we don't talk about the hypoglycemia. But wonderful, and I will request Sanjay Reddy, Treasurer of Diabetes India, to give finally vote of thanks to all three speakers. Kanan, a very eminent person who is chairperson or chairing the session, and to Dr. Amit Gupta and everyone. Over to Dr. Sanjay, and then we can close the meeting.
Thank you,
Just to
Dr.
share
Ban.
with everyone that today we have around 717 doctors who were there and listening. Even we were having registered for 2,000 plus doctors, but these many doctors who were there. In between, some goes, some see, some listen,
Yeah.
one talk, some other. So that is was there, but still it is good number. And thanks to Lupin and RX Events for today's support. Lupin support for the doctors to get engaged in this meeting, and RX Events for wonderful platform as a partner with Diabetes India. Over to Dr. Sanjay for vote of thanks.
Thank you, Dr. Bansi, for Dr. Bansi, Amit, Manoj, and everybody from Diabetes India for trying to put this program. And I was not at the ADA, and I know Dr. Bansi, Manoj, and Amit were there. Wonderful, and who attended ADA and wanted to bring the same across. What's the learnings which happened in June 2025 at the ADA Chicago, and what we're listening to are learnings from there. But ultimately, the goal is to deliver what's happening and how to use technology for better patient care. Thank you, Dr. Jyoti Dev, for enumerating on all the pump and everything on monitoring by Manoj, the controversies especially with CGM monitoring, and Supratik for getting that beautiful hypoglycemia, what to look for in CGM monitoring, and so on. And I agree with Dr. Bansi. Some of the topics are not well spoken or not spoken often. Hypoglycemia, unrecognized, underspoken, understated, and probably treated more, but not. And if you have one severe hypoglycemia in the family, then you know how difficult it is for the family to cope up for the next few days. And using technology, Manoj, getting on the controversies with CGM, we're going to get better with every time. Thank you, everybody. Thank you, Dr. Kannan, for being part and chairing the session. Amit, and all the speakers, and Dr. Bansi for spearheading the program, Dr. Arvind, and everybody else from Diabetes India. Thanks for the opportunity, and wish for more learnings in the next 3 days to come. Thank you very much.
Thank you.
Thank you, Sanjay Reddy sir, and thank you everyone. Hi, Supratik, and we hope to see you tomorrow for the session day 4 of the Snapshot of the ADA. So do join us.
Tomorrow, let's say the
Yes.
session is all on obesity and what's currently happening. I
Yes.
think it's going to be an interesting session. Amit, hope the audience are going to enjoy it because of the newer therapeutic options available for treating obesity. All these days, we didn't have such powerful tools. I think we have powerful tools, better understanding of mechanisms on obesity, chronic weight management. Look forward for tomorrow's talk. So see you all tomorrow at 8:30 p.m.
Thank you, everyone.
And thank you very much. Thank you.
Thank you.
Good night.
Thank you.
Bye bye. Good night. Thank you.
Good night. Thank you, sir.
Once you get